Hello friends, it's Zenith again here. So in this video we'll be talking about teeth abnormalities. So these are categorized under the following alteration. It could be change in number, alteration of size, change in shape, change in structure, and change of the color. So let's see what are the variation regarding number of the teeth. So if we talk about number of teeth, there could be an increase from the set of the teeth or there could be a decrease. So if we see what are the terms that are coined for decrease in number of teeth, these are anodontia, oligodontia, and hypodontia. And if we talk about the increase in number of teeth, it is simply known as hyperdontia. So we know hyperdontia is the increased number of teeth, and the teeth that are more in number or that are in excess or that are extra are called supernumerary teeth. So let's first see the details of anodontia. Anodontia can be complete true anodontia or partial anodontia. That is also termed as congenitally missing teeth. So complete anodontia is a term coined when all teeth are missing. This is a very rare condition and it is usually associated with hereditary ectodermal dysplasia. So now we see partial anodontia. It is congenital absence of one or more teeth, and usually the permanent teeth are more affected than primary. And in the permanent teeth, we see a lot of people with missing third molars, followed by maxillary lateral incisor and second premolars. And these congenitally missing teeth are rarely present in primary dentition, but if they are present, usually the maxillary primary lateral incisors are the ones that are congenitally missing. Oligodontia is a term we use when we see absence of 6 or more teeth. Hypodontia is a term used when we see absence of few teeth, that is less than 6, and hypodontia we know is the excess of teeth. So let's see the details of supernumerary teeth now. Supernumerary teeth are coined when we see teeth in excess of the normal number, and it is more commonly seen in maxilla. 90% of the supernumerary teeth are present in maxilla and 10% unseen in mandible. These supernumerary teeth are divided into supplemental or rudimentary. Supplemental teeth are called when they are in normal size and shape, and rudimentary when they are abnormal or smaller in size. There are majorly 3 types of supernumerary teeth that are present. These are paramolar, distomolar, or mesiodens. Mesiodens is the most commonly found supernumerary teeth, and we all know that it is present between the maxillary central incisors. Distomolar is the accessory molar, that is also called fourth molar, and it is also known as distodens. And paramolar is the term for the posterior supernumerary teeth that is situated lingually or buccally to a molar tooth. So a little more detail about mesiodens. It is almost always present posterior to the normal central incisors, and it is cone shaped and has a short root. So in patient you may see it erupted or impacted or inverted also. And the question that comes regarding mesiodens is the best time for removal. So it is suggested that it is good to remove just prior to the eruption of permanent maxillary central incisor. So this was all about the variation in the number of teeth. Now let's look into the variation of size. So size could be larger than normal or smaller than normal. When it is bigger than normal, it is called macrodontia, and when it is smaller, it is called microdontia. So in macrodontia, you see unusually large tooth, and it is commonly associated with hyperdontia, that is excessive number of teeth, and it can be due to a systemic disease like pituitary gigantism or pituitary hypertrophy. These variation in size is commonly seen in an isolated tooth in a jaw. So let's talk about microdontia. Microdontia is unusually small tooth, and it is also associated with hypodontia or pituitary dwarfism. The most commonly affected microdontia is lateral incisor, maxillary lateral incisor, and the term coined is peg lateral incisor. It is a peg-shaped lateral incisor, so also called as peg lateral. The third variation is change of the shape. There is a huge number of possibilities with the change of shape. They are gemination, fusion, concrescence, tuning, dens indent, also known as dens invaginatus, dens evaginatus, ankylosis, hypercementosis, dilaceration, taurodontism, ectopic enamel, abrasion, atresion, erosion, also abfraction. So let's see the detail of each one of these. First, let's talk about gemination. Gemination means a partial division of a single tooth bird. In other words, one tooth germ tries to divide in two, and clinically we see a bifid crown with a common root. And it is commonly found in maxillary incisor region of the primary dentition. The second possibility here we are talking about is fusion. So as the name says, there is fusion between two tooth germ, and clinically we see the same thing, a bifid crown with one root. The fusion may involve the entire length of the tooth. It may be fused with enamel only, or enamel dentine, or enamel dentine and cementum, or just at the root between dentine and cementum. This is commonly seen in mandibular incisor region of the primary dentition. So clinically, the both condition, gemination and fusion, they looks the same. So how do we differentiate? In gemination, as we know, one tooth germ tries to divide in two, and in fusion, two tooth germ forms one tooth. So in gemination, you see a large tooth in the dentition, but the number of teeth in total would be normal. And in fusion, you will see a large tooth with one missing teeth. So you can say the two tooth bird has formed into one. The next variation is tuning. The name itself is explanatory. One tooth germ divides into two. The twins are producing from one tooth germ. So it is the complete division of a single tooth bird into two completely separate teeth. The next thing here we are talking about is concrescence. It is the union of the roots of two or more teeth, and mainly it is caused by the confluence of their cementum surface. So only the cementum area is joined together. It is believed to be related to overcrowding or trauma, and commonly found in maxillary second and third molar. The next alteration here is dens indent or dens invaginatus. So this technically means a tooth within a tooth. So it is believed to occur due to invagination of the inner enamel epithelium during development. So the inner enamel epithelium goes inside the germinating tooth bird and forms another tooth within one tooth. Most frequently, it involves the maxillary lateral incisor in permanent dentition. This ingrown teeth has a very thin and often defective layer of enamel and dentine, and this is extremely vulnerable to caries destruction soon after the tooth erupts in the oral cavity. So this is clinically important for us because this may result in quickly development of pulpitis, pulp necrosis, or any inflammatory periapical disease in the associated tooth. If we talk about its radiographic feature, you will see an inverted teardrop or tooth-shaped radiolucency, which would be surrounded by a radio-opaque borders. So it is like looking at a teeth within a teeth. So this radio-opaque border represents the enamel of the invaginated teeth. So the next possibility here is dens evaginatus. It is the opposite of invaginatus. Another terms given to this variation is central tubercle, tuberculated cusp, or accessory cusp. This is resulting from opposite mechanism of dens indent, and here there is evagination of the inner enamel epithelium. It is commonly seen in premolar areas, more in mandible than maxilla. This accessory cusp normally consists of enamel dentine with pulp present in about half of the cases. Clinically, it will look like an extra cusp on the posterior teeth, and it is known as cusp of caribulli, and also seen in anterior region called the talus cusp. So this cusp of caribulli is associated with molars, mainly maxillary molars, and talus cusp is seen in maxillary lateral or central incisor. It is also seen in association with other variation of the coronal anatomy called shovel-shaped incisor. So if you take an X-ray of this, you will see an accessory cusp coming out of the tooth with the pulp and dentine going into the same direction. Another alteration is ankylosis. It is not a developmental problem. It is mainly replacement resorption. This happens when fusion of cementum directly occurs to the surrounding bone. And it is seen in association with hypodontia. The main factor that causes ankylosis is trauma, any chemical or thermal irritation, and sometimes, very rare, but it is seen due to genetics also. The most commonly ankylosed tooth is mandibular primary first molar, followed by mandibular primary second molar, followed by maxillary primary first molar, and then maxillary primary second molar. Clinically, the ankylosed tooth is usually found in infraocclusion and it doesn't grow more. There is no eruption. And when you percuss this tooth, it gives a sharp solid sound. It is because there is no PDL, the tooth is directly connected to the bone. The next variation here we are talking about is hypercementosis, also known as cemental hyperplasia. We know cementum deposition is a physiologic process. And excessive cementum deposition is asymptomatic and it is usually associated with vital premolars, mainly mandibular premolars and molars. So radiographically, you will see a bulbous enlargement with distinct unbroken periodontal membrane space, and the lamina dura is also normal. So there is no pathology occurring here. The tooth appears little larger in the apical area, but the PDL space is normal. The commonly associated conditions with hypercementosis are supraerupted teeth, hyperthyroidism, occlusal trauma, Paget's disease, and pituitary gigantism. So a mnemonic to remember this is shop, and how I remember this is if we have to buy cementum, you need to go to the shop. So hypercementosis is seen in all these conditions. The next condition is dilaceration. Dilaceration is characterized by an abnormal bend or curve of the root during its development. The exact cause of dilaceration is not certain, but it is thought to be resulted from a traumatic exposure during the development, usually to the primary dentition, which affects the growing permanent tooth under it. These teeth are generally asymptomatic, but if we need to do extraction of these teeth, it would be clinically difficult and may lead to root fracture on the tooth removal. Also, one more thing. This condition is very commonly seen with congenital ichthyosis. It is a genetic skin disease. It is commonly seen in mandibular third molar, followed by maxillary second premolar, followed by mandibular second premolar. The next variation of the shape, here we are talking about taurodontism, also known as bull-like tooth. So there is a problem with the pulp chamber here, and it is characterized by large and long pulp chamber. There are short roots. There would be an increased apico-occlusal height, and the bifurcation of the root would be very, very close to the apex. And generally it is seen there is a lack of constriction at the cemento-enamel junction. So it's like the elongated pulp chamber and very, very short roots. It affects the permanent teeth more frequently than the deciduous. And there is an increased frequency of taurodontism with patients with hypodontia, cleft palate and lip. This unusual root shape probably results from late invagination of Hertzsprung root sheath. Generally, these teeth are asymptomatic and no treatment is required for taurodontism, but it can be complicated during root canal treatment procedure if it is needed. So the next variation is ectopic enamel. As the name is self-explanatory, this means deposition of enamel in an abnormal area where it shouldn't be. This usually happens when the cells of Hertwig epithelial root sheath do not migrate away from the dentine, and then it differentiates into fully functional ameloblast and then deposit enamel. So there is ectopic deposition of enamel, and this is more commonly associated with bifurcation of trifurcation area of the teeth, mainly premolars and molars. And maxillary molars are more commonly affected than the mandibular molars. Two common forms are seen here. One is enamel pearl and one is enamel extension or projection. So let's see in detail. The droplet of ectopic enamel is called enamel pearl or enamelloma, and it is commonly found on the root. Radiographically, they appear as well-defined radio-opaque nodules along with the root surface. And if we talk about the cervical enamel extension or enamel projections, it is called cervical enamel extension because it is related to the surface of the dental root, and they represent a dipping of enamel from the CEJ towards the bifurcation of the molar area. So the enamel extend apically from its CEJ, or you can say there is no normal CEJ present here. So as the connective tissue does not attach to the enamel, these extensions have been correlated positively with localized loss of periodontal attachment with the furcation involvement. It is more commonly seen in mandibular molars than maxillary molars. The last variation in shape we are talking here are abrasion, attrition, erosion and abfraction. So first see what is abrasion. Abrasion is seen in the form of a V-shaped notch on the tooth, and it is generally associated with CEJ. Attrition is the variation when we see polished facets on the incisal and occlusal areas. Erosion means wearing of the non-chewing areas, and it is present on the palatal surface of upper and lower incisors. The last here is abfraction. It is again an enamel wear at CEJ, but it is different from abrasion. So if we look into the causes of these, abrasion is caused by non-masticatory forces. This loss of tooth structure is due to the non-masticatory friction, and a very good example of this is excessive forceful tooth brushing, and it is commonly seen on the cervical margin of the canine and premolar area. On the other hand, attrition can be physiologic but can also be because of excessive masticatory function, and it is commonly seen in bruxers. This kind of wear leaves a polished facet on incisal and occlusal surfaces. If we see erosion, it is the loss of the tooth structure due to non-mechanical means, mainly because of the stomach acids, and it is seen in bulimic individuals. Abfraction is again wear at CEJ, but this is due to excessive flexure to the tooth. These facets are more deep and narrow, and generally one tooth only is associated, and this may extend subgingival also. But if you see abrasion, these are more wide and shallow facets, and it is typically V-shaped in the cervical margin and associated with canine and premolar. So once again, just see it. Abrasion is the wear of the tooth structure in the cervical area. These are V-shaped facets, and they are wide and shallow and mainly supragingival, and it is mainly because of excessive and forceful tooth brushing. If we see attrition, it is the wear of the incisal or occlusal area due to excessive masticatory forces. It could be physiologic also. On the other hand, erosion is caused on the palatal surfaces of the incisor, and this is because of the stomach acid that erodes the enamel surface. Abfraction may look similar to abrasion, but it is mainly associated with one tooth due to excessive flexure forces, and these facets are very deep if we compare to abrasion. So this was all for this video. Thank you so much for watching.